We all know there is something fundamentally wrong with the way healthcare is funded in the US, and funding for behavioral health is no exception. Fee-for-service funding incentivizes providers to create business plans that depend on providing more services rather than better services, volume rather than quality. Indeed, there's even a disincentive to provide higher quality services. For instance, research, training, auditing for quality all take resources, time and money. And many of our margins are so thin that these resources needed to increase the quality of care threaten those margins. Despite spending more per capita on healthcare, our outcomes show one of the lowest life expectations at birth and higher infant mortality than any of our international peers. We also know that the outcomes of people with behavioral health diagnoses are even worse. Fee-for-service funding creates service delivery that needs to be high volume. We've all experienced crowded waiting rooms, limited availability, and a very short time with the doctor, and an assembly line approach to visits, all of which can make the medical experience difficult. But for people with behavioral health diagnosis, this approach may simply be intolerable. Additionally, social determinants often have to take priority. People have to address the more immediate needs of housing, food, or their personal or family safety. These are more immediately pressing and are a priority over the long-term benefits of taking care of any personal health issues. Any of these circumstances may even make specific appointments impossible to make. Simply put, people who have behavioral health concerns do not fit into the traditional medical high-volume healthcare practices. So people seek alternative healthcare such as emergency rooms or simply do nothing. And their outcomes prove this. The consequences of all this is the now well understood fact that people with behavioral health diagnoses have healthcare expenses that are significantly higher than those without. However, the increased expense is not in their behavioral health care, but in their physical health care, with treatment being 2 to 3 times more expensive for comorbid conditions such as diabetes. What are we going to do about this situation, as our clients are dying early? We believe that behavioral health providers really have the key to change this paradigm. As the cause of death and high medical costs are related to medical conditions, we simply can't solve this by creating a better behavioral health system. As we've demonstrated, the current medical system is failing our clients. So what's the key? Getting funders and medical providers to understand our value as part of healthcare for people with behavioral health diagnoses. That value needs to be expressed as strategy to reduce the healthcare costs. Payers need solutions to the ongoing crisis in health costs. However, as long as we consider ourselves as a separate behavioral health system, we will continue to find it hard to express that strategy. We have to consider ourselves as healthcare providers and as part of healthcare. There is a cultural gap between behavioral health and general healthcare that we need to take the responsibility to reach across. We need to approach MCOs and other potential payers, such as the PPSs, not as CBOs or behavioral health providers, but as healthcare providers. Healthcare providers with interventions that produce outcomes related to some specific health condition, such as healthy eating education for people with high A1C levels, or peer-led motivational interviewing for chronic smokers. The goal of behavioral health providers at present needn't be to get into complex VBP contracts, but approach payers with an outcomes-driven value proposition that focuses on our ability to improve physical health problems in people with behavioral health challenges.